Hi, welcome to another video. Today we'll be discussing about the drug Midazolam. So, Midazolam, as we all know, it is a benzodiazepine. Benzodiazepines themselves are categorized as short-acting, intermediate-acting or long-acting. So, the short-acting ones include the Midazolam. Intermediate-acting are lorazepam and temazepam. And long-acting drugs include our diazepam. Now, coming to the chemical structure, so midazolam exhibits a very distinct phenomenon that it has a pH dependent solubility, which means that at a pH of 3.5, it is water soluble in a buffered acidic medium, but it's lipid soluble at physiological pH in vivo. So, why does this happen? So, this property comes from its chemical structure, that it has an imidazoline ring. So, this ring, when the drug is outside the body, this ring is open, which makes the molecule polar, hence giving it the property of being water soluble. But in vivo, this ring closes, this imidazoline ring closes, and hence the drug becomes lipid soluble. Coming to the mechanism of action, it is an allosteric modulator at the GABA A receptors specifically, and these GABA A receptors, they are responsible for the fast inhibition of the synaptic transmission in our CNS. Now, these receptors are present everywhere in CNS, but they are more concentrated in the cortex, midbrain. Other structures include the olfactory bulb, the hippocampus, inferior colliculi. So, when benzodiazepines come and they attach to the GABA A receptors, they open the chloride channels. So, when they open the chloride channels, they hyperpolarize the membrane and thus mediate their effects. Now, these drugs, they have high affinity for these receptors, and this affinity is both stereospecific and saturable also. The degree of this affinity comes in this order. It is highest for lorazepam, followed by midaz on the second number, and on the third number comes the diazepam drug. So, the GABA receptor. Now, GABA has a pentameric assembly. It is built from 18 subunits, and these 18 subunits, they come in different combinations in different parts of the brain. So, this alpha subunit, it has 6 isoforms, alpha 1 to alpha 6. The alpha 1 isoform is responsible for its sedative, amnesic and anticonvulsant effects, while the alpha 2 subunit maintains the angiolysis and the centrally mediated muscle relaxation. The pharmacokinetics. Now, pharmacokinetics of midazolam, they are affected by the age, by the gender, by the hepatic and renal disease status of the patient. When taken orally, the peak plasma concentration occurs in over 30 to 80 minutes. Bioavailability is less than 50% as it undergoes significant first pass metabolism in intestines as well as the liver. When given IV, it has a distribution half-life, that is the alpha half-life of 6 to 15 minutes. Plasma protein binding is 96 to 98%, and the hepatic extraction ratio, it ranges from 0.30 to 0.44. Now, even though this hepatic extraction ratio is low to intermediate, yet it does not interfere with the clearance, as the hepatic extraction ratio is still more than the unbound free fraction. So, therefore, the plasma protein binding is not a limiting factor. The elimination half-life ranges from 1.7 to 3.5 hours. So, as we discussed above, in the physiological pH, midaz at physiological pH, it becomes lipophilic as the imidazole ring closes. So, it gets readily deposited to the adipose tissue, thereby leading to an increased volume of distribution and prolonged elimination in obese patients. But clearance is not impaired. Clearance is dependent on the hepatic blood flow. It is metabolized by hepatic CY3A4 and CYP3A5, and this is metabolized to 1-hydroxymethylmidazolam and 4-hydroxymidazolam. So 1-hydroxymethylmidazolam has about 60% of affinity as compared to the parent molecule, Both of these molecules, they are conjugated by glucuronidation and they are excreted in urine. So they may get accumulated in patients who have renal impairment and cause prolonged sedation. The pharmacodynamics. First, the CNS. So on the central nervous system, Midas has hypnotic, sedative, amnesic, anticonvulsant and centrally produced muscle relaxing properties. It it leads to a decrease in cerebral blood flow, cerebral metabolic oxygen consumption, and these effects are seen in a dose-related manner. When given intrathecally, it decreases the excitability of the spinal dorsal horn neurons, so decrease the perception of the nociceptive stimulus. And it is also neuroprotective, that it inhibits the lipid peroxidation, hence decreasing the mitochondrial damage. Coming to the respiratory system, so this shows a dose related central respiratory depression. So this is mediated by two ways. First, that it has effect on the muscular tone, which increases the risk of respiratory airway obstruction. Secondly, it flattens the response curve to carbon dioxide and it depresses the hypoxic ventilatory response. And this respiratory depression, it has an additive effect when given along with opioids. Now coming to CVS. So for the CVS, the hypothalamic paraventricular nucleus, as written here, it is very important. It is a center for the autonomic and endocrine homeostasis of CVS. And this paraventricular nucleus, it integrates the efferent stimuli for the blood volume regulation. So normally in the body, the sympathetic tone, it is tonically inhibited, which is mediated by the GABA and nitric oxide. So when we give Midas to the patient, we observe a modest decrease in blood pressure secondary to a modest decrease in systemic vascular resistance. But the homeostatic mechanisms are still preserved. These effects are also dose related, but there is a plateau plasma level. So beyond a level of 1000 nanograms per ml, if we give Midazolam, there won't be any further increase in these hemodynamic effects. Now dosages, orally it is given 7.5 to 15 mg. Intranasally it comes in a preparation of 0.025 mg per kg, which can be used for the pediatric patients. The amnesic and sedative effect, it takes 10 to 20 minutes to set in. For induction, we can use the drug in doses of 0.05 to 0.15 mg per kg. For maintenance, 0.05 mg per kg as requirement or an infusion of 1 mics per kg per minute. For sedation, 0.5 to 1 mg IV or 0.07 mg per kg IM dose can be used. It has also been shown to decrease the post-op nausea vomiting. So the dose for the same is 0.05 mg per kg and it shows a synergistic effect against PONB when given with dexamethasone. Now the adverse effects, it can cause respiratory depression, which can get augmented with the opioids. It can sometimes cause venous irritation or phlebitis, and it may also cause delirium in critically ill patients. And it is contraindicated in patients who are known to have any previous allergy or hypersensitivity to the same. So thank you for watching, and obviously this video is just for educational purposes. It is not to be used as a source for any medical advice, and always consult your books and your news sources regarding any updates. So thank you for watching, and like, share and subscribe.